excessive alcohol consumption, and the use of drugs, and medications. These are practices, whether lifestyle or not, that are linked to the rise or occurrence of infertility. So because these patterns are on the rise, we can reliably link them to, the patterns or the declines in fertility rates. Thank you.
Thank you, sir. Before I introduce Mr. Amerix, we observe that globally 45% of infertility is accounted for by men. And Kenya is among the countries in the infertility belt from Tanzania to Gabon, without a fact. Now, the question is this. Many people want to know, does frequent intercourse and ejaculation lower the quality of sperms? Mr. Juma?
I'm sorry, I missed the question.
Yes, yes, I was asking, does frequent intercourse and ejaculation lower the quality of sperms?
Well, I must say I'm not an expert in that part of biology. So maybe someone in the room who is an expert in the biology of reproduction can of course give a better answer.
Thank you. Mr. Amerix, are you on? Okay, while we wait for Sang to sort him out, I wish to get back to Stephanie. Stephanie, you're very passionate about sexual reproductive health. And when I was interviewing you, you indicated that for quite some time now, women have been bearing this burden silently. As a woman, I would love to know, how does that make a woman feel?
I think, Leon, it goes back to, and I think it's been spoken to, just the culture and the stigma around it. The burden of bearing children remains with the woman. People get married and it's the aunties, if I can call them toxic aunties, who approach the woman and say, okay, we're giving you 3 months, 4 months. We want to see some developments. And rarely do they do the same thing to men. And so it boils down to culture. And so we have to be intentional about, culture is a good thing, but culture also has some harmful and some backward practices. And so we need to look at it like a buffet, and you pick and choose, what's progressive and what works, and do away with the not so healthy stuff, which is pushing women to corners where they necessarily don't belong.
Thank you very much. Now, a lot of the conversations and the stigma around it, especially when it comes to men, and I observed this when I was at Fertility Point, which is why I'm really waiting for Dr. Rajesh to be added. I believe Sang is working on that, so that we get to understand also what are the options of treatments available, and how can we do to salvage the situations. And one of the big challenges, based on the people I talked to, I learned that Kenyans are really traveling from as far as the Busia border just to make it to Nairobi to come for treatment. And when you look at the legislations that keep on being, not making headway in parliament, you wonder what is happening. Why can't we just collectively decide and, say that both men and women, we are having this issue and we need to get it fixed? And that's where, Stephanie, I keep on referring back to you in terms of legislation. Why have MPs just refused to do their job? Because you've been speaking on them and researching on this. I don't know what you found out.
Like I said, Leon, if you compare the speed with which Parliament takes to pass laws that are aimed at increasing their salaries or their benefits, those pass real quick. The Constitution provides for example, the gender rule. The Constitution provides for reproductive health. 11 years after we've promulgated that Constitution, we still don't have those legal frameworks. So it begs the question, one, are our legislatures serious in prioritizing the reproductive health of the people that they represent? But I also want to shift back to us and throw responsibility back to us in that, how often do we hold our leaders accountable? We're going to the ballot in 3 or 4 months. In August, we're going to the ballot. How many manifestos speak to some of these issues? When we go and meet the political aspirants, are we asking them about some of these things and what their plans are for issues like assisted reproduction and how they're going to champion this in Bunge and in the spaces in which we're electing them to? So in as much as they have they have that responsibility, we as the citizens also have to step up and hold our leaders to account.
Thank you so much. While we wait for Dr. Rajesh, perhaps any doctor who's on board who can chip in as we wait for Dr. Rajesh to be added. Yeah, I'm trying to see. You could just lift your hand and I will add you to the mic. Perhaps if you have any insights to add, that will be really appreciated. But going back to the research and to Mr. Juma, are there any other instances in terms of fertility where you have found that possibly, apart from the reasons that we've highlighted already, that men are not speaking up?
Yeah, so in general, I must say that men are poor, just like doctors, they're the worst patients, either because they don't come, but if they come very late. So yeah, it's normal, it's almost a behavioral pattern for men to always present late with complications. But that notwithstanding, there have been various strategies that have been used to make sure that men, where possible, they come, they present early when, a lot more can be done much more cheaply, as opposed to presenting late when, maybe it's much more complicated. So in terms of men, and their behavior, I think it's a common trend. Even in HIV, less than 50% of men know their HIV status compared to women. So yeah, I must say that that's a common trend in a way. Nevertheless, infertility, as we have noted, comes with that heavy stigma, and there's also the fact that it's rarely talked about in the community. And I have met a colleague a couple of weeks ago, not really in Kenya, but he was a young gentleman, whom knew that he had fertility issues, and because he'd been in marriage for 6 years, not months. Every time they go for family gatherings, it's really tormenting, and it's tormenting because he knows his condition, and the wife also knows his condition. But they have agreed not to talk about it to the family. So every time they present themselves, the aunties throw in, comments here and there. What's up with you? Why are you not getting pregnant? Yet in this case, it's the man with the challenge, and in their own unique way, they have agreed that it's the lady to bear the burden of that sort of shame. To the point of, at some point, they begin recommending that maybe he should get somebody else, to give him children. Yeah, so that stands there as a major barrier. That sociocultural, elements remain a significant barrier to men seeking, services. But I also must kick back to, jump back to, the political will and the lack of attention. Because if there was sufficient attention to infertility, so that it's regarded not just as a health issue or as a public health concern, but also as a reproductive rights, issue, that all men and women or couples or individuals have equal rights to, make families, and that they should have all the means and the resources to do so. So in this case, if sufficient resources were allocated to make sure that those with various fertility issues have some level of access, or at least comprehensive access to not just the prevention, but also the diagnosis and the treatment, then of course I think would see much more people, in this case men, coming out. Because at times there's the diagnosis, but then after the diagnosis, so what? You barely have money, you have no insurance, out of pocket is impossible to achieve these types of treatment. So at times, even when they've sought sufficient information and they know the pathways to care, they still delay because they know that they may not afford it. And you can't call a fundraising, as we all know, to support you in, let's say, seeking fertility treatment. The shame that comes with it, I think, is insurmountable. So I think those are the issues that perhaps bar men from coming out, and I think they're really cross-cutting. Thank you.
Thank you so much. I wish to invite Dr. J, who can share his insights with us, especially on the available options now that men are really struggling. Dr. J, are you there?
Yeah, thank you very much. Now, I'm just going to talk about something very brief, about a question that was asked about, I think about 20-30 minutes ago. And it was about men getting infertile after they have had a lot of sex or something like that. So my take on this is that men, as men, unless something has happened within your lifetime, there is always a process where there is sperm formation. And that process is constant throughout the lifetime of a male, especially after puberty, until a man loses his life. So if you have proven your fertility, as in you have given birth to, you have fathered a child, unless something like that can interfere with the quality of your sperms, and that is not sexual intercourse, because that is the reason why you're having the sperms anyway. Now, something like you have undergone a procedure, for example, an operation that decreases the quality of your sperms, especially things like operations of the prostate or something like that. I don't think you can affect the quality of sperms that you are producing, or your fertility can be affected, because it is still the same sperms that you are producing since the time you started producing sperms. There is no alteration, and there is basically no logic to that. So I think you once fertile, always fertile. That is for men.
Okay, thank you so much. Now, we are still trying to get Dr. Rajesh. He's just texted me. He's telling me that he's having some technical hitches that he's trying to get sorted. So remember, we shall be opening the floor as well in some time for you to be able to also ask questions that you might have and clear any doubts. But for now, I wish to go back to Ms. Wandati. Ms. Wandati, how do we take this conversation forward, considering because we are looking at the state of fertility, there are many issues that have been raised. So I'm asking on behalf of many journalists who I can see here, how do we take this conversation forward, in your view?
I think because as journalists, we have the role of not only educating people, but also providing solutions. So we need to keep these stories going. We need to keep telling these stories. And the more people talk about it, the more the stigma around it will start to fall off. And the more people will realize, by the way, Kumbe, I can get help. Maybe I need to go see someone about this. Maybe it's not nothing. I really, really do need to see a doctor. And just like, I think it was Juma who said, early treatment matters. Not waiting too long might also cause further problems. So we as journalists, we need to keep these stories alive, keep telling the stories from both the perspective of the men who are affected, as well as the scientist perspective. What is science doing about it? How can science help solve this problem? Once we show that there is a solution, telling people that there's a problem and leaving it like that does not really help anyone. So we need to tell you that yes, there's a problem, but there's a solution as well. And this is the solution that you can seek if you're affected. If we keep doing that as journalists, then pretty soon, maybe in a year or so, the stigma around talking about infertility issues will then start to fall off, and then the conversation will start to grow louder. And when the conversation grows louder, that's how then maybe we'll have better leverage to push for legislation. Thank you.
Thank you. Jay, what causes this problem? Perhaps you could elaborate more on that to us from an expert point of view. Dr. Jay, are you there? I don't think Dr. Jay is with us. Perhaps if I could transfer the question to Mr. Juma.
Okay, so maybe I'll respond as we wait for Dr. Jay in terms of why are we not making progress? Why is the problem persisting? Indeed, there's been slow progress on infertility. Infertility is not a new issue, even though increasingly the prevalence is on the rise. But I think part of the reasons have been highlighted earlier by previous speakers, which is the lack of attention to the lack of attention, whether at policy or implementation level. But also from a research perspective, I must say that one of the biggest challenges we face is the challenge of unknown epidemiology, which means that we really do not know the extent to which infertility is a challenge, apart from the anecdotal evidence that we get either from clinic-based studies, which we know are definitely biased, because you are picking from a very highly selected group of people. So the challenge of understanding the epidemiology really prevents action, because then we are unable to understand that burden, and then the causes, the determinants, as well as the barriers to access of quality services. In this case, quality fertility care. As such, it is very difficult to track progress or to track any action. And so there's a significant level of ambiguity in terms of really the extent and the burden of infertility. As such, it then becomes a very difficult public debate, because the very first question, policymakers normally ask is, what is the burden? How many people are affected? And then you have to give them numbers, and you have to give them, the burden in terms of economically, socially, of this burden. So as long as we will not be able to quantify that number with much more precision, then the challenge of infertility sort of will remain significantly unaddressed. And I like the options given by previous speakers, that if media plays its role, if research also plays its role, and there's a collaborative effort in terms of communicating and amplifying the voice of the voices around the burden of infertility, lived experiences. If we told stories of persons who are going through this challenge, then of course we'll get much more traction and appetite, on the part of policymakers to at least move forward with policy and perhaps guidelines to ensure that there's access to quality services. Now, much more importantly, I must mention that one of the key barriers to policy making process, we have mentioned certain bills that have been tabled in our National Assembly, and they all fell flat. And the big question is, why did these things fall flat? Why did these bills that are supposed to create a suitable framework for addressing this challenge, fail to get the attention of these, honorable members of parliament? Of course, one of the biggest issues we suffer from is, the untruths and misleading information that most often lack any scientific backing. I'll give you an example. So there's a lot of opposition towards elements of surrogacy or even assisted reproductive technology, based on, as arguments would go, that children born from IVF would perhaps be facing certain cognitive or developmental challenges. And of course, studies that have combined vast number of, experiments across the globe have shown that, that is just not true. And yet these untruths, continue to be deployed, especially on social media. And of course, they affect our members of parliament. Now, these untruths also find roots in the fact that there's a general lack of awareness amongst the people. And so when these untruths are systematically deployed, they generate a certain sense of fear, moral panic, and then they emotionalize the topic. And after that, no constructive debate can occur, as long as those untruths have taken root. And so there's a general, opposition, which is not necessarily scientific, but largely based on misinformation and untruths. And we've seen that a lot in the sexual and reproductive health space. I feel that this is one of the barriers that we have to address, moving forward. Thank you.
Thank you so much. Before I go to Dr. J, I've just seen someone has tweeted, when you're talking about social media, someone has tweeted me and said that we know family planning affects men. Is that true?
Okay. Yeah. So I'm not so sure how the question is framed and what it's supposed to mean, but one of the myths around family planning and contraceptives is that it causes infertility. I mean, that's a myth that is not recent. I mean, it's been there for quite a while. And I think in as far as the use of family planning is concerned, most often the side effects are really individual based and cannot be generalized. So it's often really a conversation one can have with a provider, with their provider, to be able to get appropriate information as to which family planning method is appropriate for them, which one will not give any undesirable side effects, and which one, of course, fits with their fertility preferences. If you want to give birth in the next 3 months or the next 1 year, which one really fits you? I think that is information that is most reliably obtained from a health provider and not on social media. Thank you.
Thank you so much. Now, Mr. Sang tells me he has found a way to link the Dr. Rajesh to us. But before we go to Dr. Rajesh, Dr. J, I had asked you before you dropped off, what causes this problem from an expert's point of view?
Now, the problem of infertility is it is very broad. It comes straight from the male, because the male or the man can be affected, and also the female, because the female can also be affected. So, from the male point of view, it is mainly a defect in production of sperm, either in amount, quality, amount of live sperm, and also something to do with the female factor that is able to kill the sperm once the male has ejaculated into the female. And also there can be defects within the system that releases the sperms, and therefore you find that the sperms are going in the wrong direction. Also, the other thing, in females, it can range, especially from defects within the system. The system can be very ambiguous at times, whereby the anatomy or the structures, they are not aligned properly, and also the structures do not allow the implantation of the fetus or of the embryo, rather after fertilization. Also, if the person has previously aborted, it is also very serious, because at times when these people abort, they tend to develop something else that is called uterine synecdoche. And in this case, they form adhesions within the uterus, so the thing is quite not very favorable for attachment of the embryo. Also, the other thing is previous surgeries. Also, surgeries can make someone infertile, especially surgeries that can interfere with the pathway of the sperm or of the ovum, especially if someone, for example, got an ectopic pregnancy before and it ruptured, underwent a surgery, and probably they did something like they cut the tube a bit, they ligated the tube. It can make someone infertile. Generally, there are a lot of things, surely. Also, things to do with hormones. People can be infertile just because of their hormones. A problem in the brain affects an axis that connects either the brain and either the testes and or the ovaries. It affects the production of these cells that have the ability to be fertilized or to fertilize. And about family planning causing infertility, that one is quite it's quite rare. But when you put things like we are not sure about this, but things that are put, for example, that we used to be put a long time ago, things like these active copper metals that were put before, probably, and the patient gets infected in the uterus, it can result into formation of adhesions, which can make the environment within the uterus also quite not very receptive to the fertilized embryo. Oh, sorry, and also things like these guys who masturbate a lot and they end up getting things like erectile dysfunction. I think they lose their self-esteem a lot. They disturb their brain a lot, and therefore, at times when it reaches the time when they are supposed to act, they end up underperforming a bit. So it kind of affects their psychology. And these guys, they find it hard to finish up with this, and so it can also kind of result into some sort of secondary infertility.
Okay, Doc. Now, why is this problem so prevalent among men now, and what can they do?
Now that is a question that is quite not very easy, but men these days the world has changed a lot. And it has changed in an aspect whereby these days there is no guarantee that you're going to get a mate, in terms of finance, and also in terms of also the ability to live with a woman where you're supposed to live with a woman. And so guys, a lot of guys resort to masturbation, I think. And I think this is a serious problem. And personally, I have seen a lot of people that have come to me because of this problem. They end up getting an erectile dysfunction because of constant masturbations that can happen. And therefore, the problem is not that the guy doesn't have sperms, but the guy is having a disorder that pushes him to only masturbate. And when you masturbate all your sperms out, it means you need time for your sperms to get back to the normal count. You need time for yourself to also, for your brain to readjust, and also for you to ejaculate a right amount of sperms that have the right maturity. And I think this is the problem. So, and the other thing is because these days we are used to seeking healthcare a lot. So when a guy is having a problem with getting children, they have to go to the hospital, and therefore we get to see more numbers of guys that have this problem. And also previously, a lot of women used to be blamed for even the problem of men being infertile, because people used to think that it's only females that can be infertile. But now, because of advances in medicine and also research, we have been able to know that even men have this problem. So the healthcare system gets to be in contact with more cases than they were before, and therefore that is why people come to realize that this problem is actually a serious issue and needs to be addressed.
Thank you so much, Dr. J. Now, I wish to move to Madam Kendi Ashitiva, who's a counseling psychologist. Now, Kendi, good evening.
Good evening, everybody. How are you?
Fine, thank you. What have men been telling you? What have they been whispering to you when they come for counseling on this issue?
Okay, like someone said, men make very challenging patients. Let me not say bad patients. They make very challenging clients, because by the time they come, they're in ICU. We are resuscitating their relationship. We are resuscitating their self-esteem. We're resuscitating their sense of identity. Like, things are literally going to the dogs. So what I see a lot are couples having difficulty having children. And so I see primary and secondary infertility. I see couples that are going through IVF. I see couples who have had several failed IVF attempts. So I tend to see more couples than individuals in terms of just the men. They come together as man and wife. And I can tell you it's a treacherous experience. It's a painful experience. One of the things we say as therapists is that, the whole process of infertility and difficulty carrying to full term, it is considered what you call disenfranchised grief. Disenfranchised grief is the kind of grief you go through, but you can't really share. You can't tell people, because it's not considered by social standards as something we grieve. We know you grieve the loss of a child, loss of a loved one. We grieve things that were alive, then they have died. But we don't consider hopes, dreams, and aspirations as things that are actually alive, but they are. So when you desire to have a child, a hope comes alive, a desire comes alive, something you knew is alive. And with every failed attempt, there is some sort of death. So I see women coming and say, Kendi, my period came again. I fell apart in the office. I literally had a panic attack. I have men say, I'm so embarrassed. I don't know what to do. I feel like half a man, literally, like she should just go off and have a child with someone else. We are considering trying to get a donor sperm, So the amount of shame surrounding the whole experience is very difficult. And sometimes the couples don't even know how to talk about it. So one of the things we do is to teach, how do you talk about infertility? As a couple, how do you go through that valley of the shadow of death together as man and wife, and not allow this to even kill your marriage? But it's a painful experience. I can tell you for free, with every failed attempt, with every fail, like the doctor said, with every difficulty having and maintaining an erection, there's a sense of loss, and we can't pretend that it is okay. It is not okay. It's not okay. It's difficult. And so just calling it what it is, one of the things we do in therapy with couples, saying that it is tough, it is painful, you can feel feelings of shame and inadequacy, like what is wrong with me, And remember, many of us growing up were always told, don't play with girls, you'll get them pregnant, and girls are told, don't play with boys, you'll get them pregnant. So we were made to unconsciously believe that conceiving, getting pregnant, it's such a default experience, It's so easy to get a girl pregnant. You literally went through your teenagehood and your young adolescent and young adulthood trying not to get a girl pregnant. And this one time when you're trying to get a child, nothing is working. It becomes a very difficult cognitive shift. Like, how do I move from this one thing I have tried all my life not to have, and it's the one thing I desire the most? So I think in a nutshell, I can say the pain around it, the sense of loss, the sense of shame, the sense of failure, the sense of inadequacy, really just what we call disenfranchised grief. This is grief that you experience that you cannot really share because it's not considered shareable. You can say in the office, my mom died. I can say in the office, my liver is failing. You can say in the office, my pancreas, I'm not having enough insulin. Let me go and shoot up some insulin. You can say some of those things, but you really can't see across a table that it's been 5 years we don't have a child because something is wrong with me. It's very difficult. Something else I've seen as well is the men, I've seen men who even after finding out that they are the ones that could use medical interventions, they still resist as part of the denial. So I've seen a lot of denial. I've seen men who the doctor tell them to their face, listen, you need to take this medication to increase your sperm count. And they just don't take it. Or they just don't show up for a doctor's appointment. I've worked with women who just sit there and wait for this guy to show up and wait, and he never shows up until the clinic is closed, And so this woman goes home feeling so heartbroken because instead of being a 2-man journey, it's become a 1-man journey. He doesn't want to face the fact that there's something wrong with his sperm. So we need to normalize the fact that your sperm is just like any other biological fluid. It can have challenges, and there's medicine that is designed to help you. There are doctors that have specialized. And I remember telling one man, the same way I took on psychology and mental health because I love taking care of patients, I love taking care of clients, the same way someone else went and studied reproductive health. This is a doctor who has focused on this. They do it passionately. They have an innate compassion for people that are struggling to conceive. So you're not going to someone who is frowning on you or raising their nose at you. You're going to a healthcare provider who has chosen to do this for a living. So just to encourage those that are struggling in our midst, no doctor, no therapist is on the other side of that table looking down on you. No. We train for this. We prepare for this. We look forward to helping people in difficult moments. So please reach out. We don't have perfect bodies. And if your body is not doing what it's supposed to do, I guarantee you there's a scientist somewhere who has spent tons of money trying to figure out how to help you. So my final remarks, at least for now, Leon, would be, if you're embarking on an IVF journey, please sign up for therapy as well. If you're any fertility treatment, because they tend to be emotionally draining, financially draining as well, please, see a therapist as you go along that journey, Let someone else walk with you and try and help your mental health, even as you go through the process, because the highs and lows of fertility treatments are real. The hormones that you may have to work with may affect your mood, may trigger anxiety or depression, may just really make you feel uncomfortable. And so it's important, alongside your clinician who's helping with fertility treatment, also just see a therapist, so that you don't go to your OBS-GYN or your fertility expert and think they're a therapist. They're not a therapist. So they may not have an hour to give you to help you offload the emotions of the process. But even if they want to, it's not their core business. So I'd really encourage anybody going through the process, see a therapist as well, just so that you're able to go through it as intact as possible. Yeah.
Thank you so much, Kendi. And perhaps you've said that couples come to you, right? So when they come as couples, I remember when I was doing this story and I was talking to the IVF expert, he told me that age is one of the leading factors when it comes to fertility to consider. And according to him, very many men and women focus so much on chasing careers. By the time they decide to settle down and have children, and start a family, it's too late to a point that they end up spending all the labored for in finding that one child. So what do these couples tell you? What really goes on in their minds when it comes to the age factor?
Okay, that sounds like a sociological question. What I would say is this. Indeed, our lives have changed. Our primary focus has changed. When we were raised by mothers who had 6-7 children, these same mothers told us, before you get married, make sure you get at least a master's degree. These same mothers told us, make sure you have your own money. Make sure you're not depending on a man. Make sure, these same mothers that had babies at age 18, 19, 20, were very clear to tell many of us, you know what, I lost something. I lost options because they never got to advance their careers. So I think every generation tends to hand over a challenge to the next one. And it mainly comes from the losses they experienced, what they wish they would have done better. So indeed, there's a whole generation of people once born in the 70s, especially mid-70s and above, the 80s, that were really encouraged. And there was a lot of women empowerment movement that encouraged us to go to school. The other day, I went for a graduation party for a young lady who had she done her undergrad or no, she just finished her undergrad, and so she was graduating. And she's 24, 25 years old, and nobody mentioned the idea of marriage in their speeches. Everybody told her, go for your masters. The entire conversation leans towards progress your career. Nobody told her, no, mommy, we are waiting for the young man that you will bring, we're waiting for grandkids. That never came up. And I found it very interesting that even the older generation was encouraging her to go back to school. And she herself said, yes, I have already applied. I'm looking for universities out of the country. Her leaning was not on family. Her leaning was towards career progression. So there's, of course, a narrative and a desire by most of us to progress our careers. Is that little science? I know, and I say little, is that it's not easy to have a direct cause and effect relationship when it comes to infertility. There are many other things, and I think a certain doctor mentioned on this call. There are other small things, other variables that affect fertility. So yes, many of us are having children older, and we have to realize that is our new reality. Many of us are finding it taking longer to find a mate. How many times do you hear people say, hey, don't rush into marriage, take your time and get a right partner, take your time and marry a right man. That take your time ends up affecting another area of your life. Now, that does not mean that you cannot have children slightly older, but it means it may become challenging, and I'm sure there's a doctor on the call who can clarify that. Most OBS-GYNs will tell you for a female over the age of 35, you may start, it's not as easy as it is when you're younger. There's science to back that up. So indeed, because many of us are leaning towards individuality, we're leaning towards financial security, we're leaning towards identifying what I want to do, what makes me happy. And remember, we're raised by many mothers who never got that. So I don't know if that answers your question. Of course, the age factor affects the women more than it affects the men. because like I think it's Dr. J who said men are fertile forever, if I'm not wrong, for a long period. So yes, getting married older may come at a cost. So you have to decide what price you're willing to pay for what reward. Yeah.
Thank you so much. Perhaps if Juma could dissect age for us from a research and scientific perspective in relation to fertility.
Well, thank you, Leon. I think exactly just building on what Kendi has said, what we have seen from a research perspective is that there is a transition in terms of the earlier, the previous adolescents and teenagers are not the same, adolescents today. So, as I'd earlier mentioned, previously by the age of 15, 16, really, someone was ready to get into marriage and manage. However, because of competing interests and priorities in our current days, at that age, really, someone is so immersed in educational pursuits, career, and that goes on until maybe late 20s, when now they can sit, look back and reflect on whether they are interested in getting into a marriage. And of course, such is the transition that occurs, that then ultimately intersects with reproductive, capabilities, and at times may result in difficulties getting a child at some point. However, I would not be quick to say that age is the main driving factors. Factors are indicated earlier. There is a concurrence in terms of patterns of disease. As we stand today, there is an immense burden of chronic illnesses, amongst them cancer, diabetes, and so on and so forth. Some of which either the disease itself or the treatment to these diseases may intersect with reproductive capabilities. So at the end of the day, while these diseases were previously known to occur at later ages, there is factors. These diseases, as mentioned earlier, include smoking, lack of physical activity. There may be an element of excessive alcohol consumption. They're the same risk factors that are associated with the occurrence of infertility. So as you see the disease patterns changing towards chronic diseases, some of these risk factors that are driving these patterns of chronic disease are the same ones driving the issue of infertility. So at the end of the day, age then is really central, because as you live longer, perhaps you're more exposed longitudinally to these risk factors. So you're more likely to, express the results of exposure to these risk factors, out of which then infertility may occur. But I also see, Dr. Catherine here. I'll just call her out if she has something to say on chronic diseases and the risk factors, as well as how they may intersect with infertility, if she can. Otherwise, thank you, Leon.
Thank you so much, Juma. Dr. Catherine Kyobutungi, welcome. Dr. Catherine Kyobutungi is the Executive Director at the African Population Health Research, and she'll be tackling the question Juma just threw at her, and also talking to us about the options that we have in terms of treatment. Thank you. Karibu, Dr. Dr. Catherine, are you there?
Hello, can you hear me?
Yes, I can hear you.
Yes, thanks, Leon. Happy to be here. I joined a little bit late and just found the spaces ongoing. And I'll just add a little bit about what Ken just talked about in terms of age and other risk factors. Of course, all these risk factors, Ken has talked about them. But what I wanted to sort of emphasize is the fact that sometimes, as I think the previous speaker said, there's no real cause that can be identified about why things are not working out the way they should. And sometimes age is not a factor. So sometimes there's an assumption that certain things are more prevalent, which is correct, but prevalence and probabilities don't mean that you can't fall on the other side. So you can't be young and healthy, no risk factors, but still the natural way of conceiving doesn't happen. But having said that, of course, after a certain age, risks are higher. And I know, for instance, that beyond a certain age, especially for women, even those who want to pursue fertility treatment, the success rate keep on decreasing the older somebody gets. So at around 35, the chances of successful fertility with somebody's ova or eggs are a certain percentage. When you get 39, it's a different percentage. When you get to 40, it's a different percentage. So the percentages keep on getting lower and lower and lower. And that's why it's important that when a couple is trying to conceive and they have problems, there's a thorough assessment which is done. And based on that assessment, your age, the risk factors you have, and then, of course, any physical examination or tests which are done, there's a customized treatment plan. And this is dependent on what is the cause, what is the likely cause. Some causes can be fixed, some causes cannot be fixed. And I think now the trends in what is known as assisted reproductive technology, in the past, if you had a blockage of the tubes and you're a woman, there were all these treatments to try to unblock the tubes and try to give you, sorts of treatments to clean up the system. But then now that is rarely done because it's much easier to do what is known as IVF, get out the eggs and fertilize them outside and then implant the embryos, than trying to fix a physical, maybe a physical damage or a physical deficit that exists in the reproductive system. But what I wanted to say is that there are so many treatment options. And so even the issue around if you're a woman and let's say you're in your 30s or in your 40s, or you are a man, the topic today, the article said shooting blanks. If you're a man and you're told that we've done an analysis of your semen and there's no sperm in it, there are many, many, many treatment options currently. The technology has advanced and it's costly, but it's possible. And maybe one of the issues that I would wish to see a discussion about is the issue of cost, because it's very, very expensive to try to get the best treatment that is possible based on whatever analysis has been done on the couple. So when it comes to the treatment options, really the simplest treatment option, if, for instance, the problem is that the couple is having sex, there's no more, and there's an erection, and an erection is sustained. The man is ejaculating, but for some reason, fertilization is not happening. Based on the assessment, the simplest form of treatment is for the man to provide sperm, usually through ejaculating in some kind of container, and then the sperm is inserted into the woman's reproductive system. It's like an injection. They just get the sperm and inject it. And sometimes that's like the simplest form of assisted reproductive technology. And in some couples, that's enough. So it's almost like the way sperm is obtained and inserted in by the veterinary doctors in cows, artificial insemination. That happens. Now, if that doesn't work, if, for instance, the sperm has been inserted, the sperms are healthy because when somebody provides the sperm, it's actually examined under the microscope to see whether the sperm are healthy. Are they mobile? What are their numbers? Do they have normal shapes? So there are different metrics of saying that the sperm is healthy. So it's just inserted into a woman, and sometimes that is sufficient. But that is the simplest form of technology. When that doesn't work, usually the second level of complexity is getting the sperm itself, and then the woman has to undergo some kind of treatment to produce many, many, many eggs, which are known as ova. The eggs are removed from the woman. They are put in a test tube. That's, I think, an illustration of the process. And the sperm are actually put on the eggs without any kind of manipulation. The eggs are in some kind of container, and the sperm that has been received from the man is powered on the eggs, and fertilization can happen. So in that case, when fertilization happens, then the embryos, after a few days of development, are taken, and now the embryos are inserted into the woman, one embryo or two. The practice varies from country to country, but it's possible that you power sperm on harvested eggs or ovum of the woman, and fertilization actually happens. And then the embryos now are transferred into the woman. That is what is commonly known as IVF. So that assumes that the man can ejaculate and that the sperm are healthy and that there are sufficient numbers and they are all healthy. So that can happen. Now, things become problematic when, as from the article, the focus was more on men who either don't have sufficient sperm, or they don't have sperm at all, or they have unhealthy sperm. So in that case, now the treatment gets more complex, because you can't power unhealthy sperm and you expect fertilization to happen. So in some instances, the man ejaculates and the sperm are picked out. The healthy sperm is picked out from the ejaculate, and then now the same thing happens. If they're enough, they're poured on the eggs and fertilization can happen. But if the man is shooting blanks, as has been said, sometimes there are different problems. One of the problems is that the man is actually producing sperm in the testis, but there's a blockage in the tubes that are supposed to transport the sperm during sex or during ejaculation. So there's a blockage that the sperm cannot pass that blockage. So if that is the case and the sperm are there in the testis, they can actually be extracted. And if they might be stuck in the tube somewhere, but this is determined based on the investigation. So it's a simple, it's not simple how somebody has been trained to do this. It's getting a syringe and finding the tubes, and then putting the syringe into the tubes and extracting enough sperm. But in this instance, the sperm are rarely enough that you can just pour them onto a receptacle that contains the eggs. So there's another more complex procedure where the sperm is sort of physically injected into the egg. So when you think about the size of an egg, this is done under microscopy, because the size of an egg is like getting a pencil and making a dot on a piece of paper. So that is the size. And if you imagine the size of a sperm, the sperm is smaller. So what happens is to get this sperm and under a microscope, physically inject it into an egg. So that's a much more complex level of technology. And the same process is done if, for instance, it is found that it's not a blockage, but the testes are not producing enough sperm, because sufficient sperm is in the millions of cells within a small amount in terms of quantity. So the person may actually not be producing sufficient sperm, or the sperm are not healthy. So the same process can be done where now, instead of looking for the sperm in the tubes where they are stuck or blocked, the injection is done in the actual testicular cells or tissue. And an extract is done of the tissue itself, and under a microscope, sperm can actually be isolated from that tissue. And the same process of getting a sperm and injecting it into the cell is done. Now, a much more complex is if even by doing that, like a syringe is put into the testicular tissue and no sperm cells are identifiable, it's actually possible to do surgery, still under a microscope, that the testis is cut open, and you can actually, under a microscope, tell that these are cells that are likely to contain sperm. So a small piece of the testis is cut out, and then it's dissected, and then the sperm is extracted, and then again injected into the ovum. So as I've said, there's much more complex technology. And I think if you fail at the point of cutting testicular tissue and extracting sperm from it, and then injecting it into a woman, if that doesn't work, then usually the other option is to get the donor sperm. So couples are still given that option. As I've said, there are many treatment options. And if the couple is okay that they can actually get a donor sperm, then the sperm, they are sperm banks, the same way they are like blood banks. People go out there and they donate sperm and it's kept. So if really it's not practical to have conception happening as a result of the genetic material, which is the sperm and the ovum from the couple itself, then there's also option of getting donor sperm. Now, going to the side of the woman, it's also possible to get donated eggs, especially, as I've said, women who are a little bit older. Sometimes it's possible that when you provide your eggs, then they're examined and maybe they are found not to be healthy enough, or when they try to be fertilized, they don't fertilize. So there are also options of getting donor eggs. There are also donor egg banks. So as I've said, there's a lot of technology out there. Of course, cost is an issue, but it's also to say that really depending on the circumstances and the reasons why a couple is not conceiving, that people can actually have a baby, having gone through all these options that are out there. So I'll stop there and see whether there are any other questions or whether there's anything I need to clarify.
Yes, Doc. There are 3 questions so far. The first one, are there genetic alterations in men that are leading to this issue?
I think that would require some kind of study that shows what is going on specifically in this. Hello?
Yes, please go on.
Yes, I think that would require some specific studies to find out some of those genetic things, to say whether they can explain what is being observed. But having said that, there are some genetic predispositions that maybe perhaps may cause other conditions, because you may have heard, for instance, that things like obesity may lead to some maybe hormonal imbalances that may lead to some other things. So directly specific genetic issues, maybe not so much. But to answer that question as it applies to Kenya, for instance, that would require an understanding of what are the actual drivers and what are the actual causes. But I wouldn't necessarily say that genetic factors are playing a role.
Okay, and that leads to the second question. What is science showing, and is there a global body of research looking into the problem?
I think your article is based on some global body of research that's showing, generally speaking, that over time, sperm counts, sperm quality are going low. Yeah, and this is not just a Kenyan thing; it's actually a global phenomenon. Of course, there are different explanations, things like pollution that we're exposed to. We're exposed to all sorts of harmful chemicals, whether it's in the air, whether it's in the water, whether it's in the soil. So there are so many things which are happening. And then, of course, those other things about, human behavior, things like tobacco use. So there's actually an understanding, generally speaking, globally, that the quality of sperm in men is declining. But as I said, the drivers vary from country to country, and of course they would vary from individual to individual.
Awesome. Now, based on your explanation on the donor sperm, someone wants to know if they go out there and get sperm from donors, when they're now doing IUI in women, do they get to choose like the quality of sperm, whether the baby will come out light skin or the height, so some of those qualities?
So what happens when people go to donate sperm? They provide information. They provide photographs. So there are certain things, some attributes that are part of the donor's profile, and the recipients have an option to actually go and say, I want people who are not too light skinned. I don't want people who are too dark, because you've heard about the stigma that couples who can't have children face, and nobody wants to go out and say, I got donor sperm. So, and then the child looks completely different from the couple. So there are those things. The people who provide these services are sensitive to the societal stigma and societal perceptions. So people can actually choose certain attributes, and it's possible to get guidance about if you, for instance, the people who provide the services themselves can actually filter and say that perhaps these are your best candidates based on certain things. In some countries, they provide even information about things like education status, like the current job, because some people want, donors who are doing sciences or artistic, so there are different things, athletic. So in some countries, actually, the profile can be quite detailed. And so people can choose. I'm not sure about the practice in Kenya about whether people can actually see the photographs of the donors, but it's possible to choose and say, I want somebody who's not too light-skinned or too dark-skinned, depending on what people want. But I think ultimately, over time, it's important to have these kinds of conversations to destigmatize, the methods in which people want to have a family. Because if that wasn't so important, it wouldn't really matter whether the donor is tall or short or light-skinned or not. It wouldn't really matter. And I think if a couple decides that they're going to get a donor sperm or a donor egg, at the end of the day, they want a child. In whichever way they can get a child, they can call their own. And so I think, when couples are counseled, I think the counselors can also chip in here. A child is a child, ultimately. But society needs to maybe also get to the same level of really understanding the choices people have to make. And if a child is a child, then whether the child looks like the parents or doesn't look like the child, I mean, like whether it's too light or too dark, it really shouldn't matter. But those are things which we still have to work with as society in terms of the stigma that is attached to infertility.
Thank you so much, Daktari. Guys, remember, we are nearing the time for you to ask questions. So on the heart-shaped icon at the bottom part of your screen, you can click there and raise your hand in case you have any questions, and I will give you the mic. But before we go to that, I'm told Dr. Rajesh is around. And Dr. Rajesh, how are you? Good evening. Dr. Rajesh? Sang, please help him access the mic.
Hello.
Yes, Dr. Good evening.
Good evening.
Yes. Please introduce yourself.
I'm Dr. Rajesh Chaudhary. I beg apologies for the technical fault this side. I am working at Fertility Point as a lead consultant, and I'm here in Kenya for our last 1.5 years.
Thank you. Thank you so much, Daktari. Now, Daktari, what treatment options do Kenyan men have when they visit you?
So, first of all, we need to find out what extent of the problem is there. The patient, when they come with low sperm count, or they come with totally no sperm, so these two different problems they can present with. So if there is suppose a very low sperm count, which we see that there is a problem with the count, the motility, and the morphology. Sometimes all these three parameters are down. Sometimes only motility is down. So if there is a problem in the count, hello?
Hello, yes, we are listening.
Yeah. So we first try to find out what is the reason behind it. So we do a few tests. We do a scrotal examination, and then we do an ultrasound on scrotum to find out if there is a varicocele present. Sometimes varicocele can cause low sperm count. On history, we can ask them, is there any history of infection at childhood or any trauma? Then we do some hormonal test, and then we see what is the cause of the low sperm count. Sometimes they come. There may be a history of, there may be a history of some drug consumption that can lead to low sperm count, like antidepressant medicine. So all those possibilities had to be explored.
Thank you so much. Now, how many?
And then the treatment option, like if there is a varicocele, then that varicocele has to be surgically treated. If the cause is on the some drug consumption, like antidepressant, some certain antihypertensive medicine, that has to be tackled first, right? So sometimes, these young men, they present with low sperm count, and then if you can see a very good bodybuilding, and then if you ask, they may be supplementing themselves with external testosterone supplements, and then that can even cause low sperm counts. Sometimes the obesity, the more fat in the body, they cause low sperm count. So if these are the things, then they don't need any medicine. Just if you ask them to reduce their body fat, reduce the weight, that can lead to improvement in their sperm. If they are taking external testosterone, ask them to stop that over the time, the sperm count will improve. And then there are certain food supplements, a sperm booster, that you can prescribe, and then that can be improved. Now, if the situation is different, like if there is no sperm at all in the semen, then you have to find out whether the testis is still producing the sperm or not. So you do the certain blood test, and then we can find out whether it is a obstructive type or non-obstructive type. If it is obstructive type, then doing some surgical retrieval of sperm directly from the testis can yield some sperm, and that sperm can be used for IVF purpose. That can be injected in egg after IVF, and then we can create embryo, and then the pregnancy can be achieved.
Okay, Dr. I wish to bring back a question I'd asked Dr. Catherine earlier. Are there genetic alterations in men that are leading to these issues?
There are some genetical issues, like there is a condition called Y microdeletion. That is a genetical condition in those men who are presenting with agiospermia. Almost 5% of them are affected with this genetic condition. And then we can do a test to detect this genetic condition, though it is a bit expensive, but it is worth doing it. Because if pregnancy is achieved through the sperm affected with this genetic condition, then it can be transmissible to the offspring as well.
Yes, Dr. And how many men go for treatment, and what does the success rate of these treatments in Kenya look like?
So if it is a low sperm count, say if it is between 5 million to 10 million, then IUI can work out. And then we can try for 3-4 cycle of IUI, intrauterine insemination, where we take the husband's semen and then process the motile sperms are then inseminated inside the uterus at the time of ovulation. Now, if that works, fine. If not, then they are the candidate for the IVF ICSI. And another population of the agiospermia, if it is obstructive type, then those sperms, even they are candidate for the IVF. So the success rate with, if there is no associated factor involved in women, so the male factors in IVF for male factor, the success rate is quite good.
Okay, now just before we move to questions from the public, when you came in, we were discussing about donor sperm. What do you consider when you are taking sperms from donors? And there are women who want their child to look in a certain way, for example, to be light-skinned, to be tall, to be handsome. Do you also, what is the process, basically?
So those who are wanting for a donor sperm, for IVF or donor sperm IUI, so we first select any clinic select the candidate. They have a bank of profiles of the male donors, where all these male donors are screened first with the semen analysis, and then only those candidates which have a very good semen profiles, they are selected. After that, we do certain other tests like viral test, HIV, hepatitis, and blood grouping, and we also ask a certain history of like any genetic disease in the family. But we don't do generally any genetic screening on those donors. So now and then we make a bank of all those donors of different characteristics. Few client may come asking for a Somalian donor. Few client may asking for a Caucasian donor, on different race, different height, and different complexions. few even ask for certain educations. Now, the education, though it doesn't affect the education intelligence is not transmissible to the offspring, but even such demands can come. So, but for the medical point of view, what important is how good is the sperm and what is the blood group? Because even if the recipients are a different blood group, and the donor should not be different blood group. So even blood group should be matched.
Okay, thank you so much, Doc. Please stay on. I wish to give the mic and open the floor to questions. Let me start with Boni Ushe. Boni, please take the mic. Boni, are you there?
I'm speaking now. Can you hear me?
Yes, I can hear you, sir. Please go on.
All right, thank you. My name is Boniface Ushie, and I work at the African Population and Health Research Center. And this issue we are discussing is of interest to me. I have one clarifying question that Dr. J or the last speaker, I think that's Dr. Manjo, can take. Dr. J made a comment about that the frequency of sexual activity for men on its own does not decrease the sperm counts or the viability of the sperm or the potency of the sperm. And then later on, he said something about masturbation. And there has been discussions that have been privy to where people say, oh, masturbation can lead to infertility. There's all that arguments going on, and then there is some scientific literature that is saying that argument is a myth. So I would like to hear here either from the medical doctors on the call on the panel or anyone on here whether it's truly is real that masturbation can cause that, because it seems that is some kind of argument that parents or morally minded people use in telling people not to have pleasure with themselves. That's one question that I want to ask. But also, Dr. Manjo, I've sent you, I followed you. I wonder if there's any way I could get in contact with you as part of this interest in infertility research. I have many other comments, but I see time is coming to an end. Let me stop with that question about masturbation and infertility.
Dr. Rajesh, please take on that. Yes, please put on your mic. Sang, please, can you help him put on his mic? Okay.
Hello?
Hello, yes, sir.
Yeah. So, I'm sorry. So I'm Dr. Rajesh. I'm using my wife Twitter account, Manju. She is Manju. So you can contact me at Fertility Point, that is in 40 Suite, Upper Hill. Regarding your first question, whether the excessive masturbation can lead to infertility or not. So, hello?
Yes, we can hear you.
Yeah. So there is no direct any evidence saying that excessive masturbation, whether it will lead to infertility or not. But anything that is in excess is a bit harmful. Even if you take a vitamin in overdose, I mean, that is not good for the health. Excessive masturbation is like something that it can affect psychologically, leading to some premature. I mean, I don't know. There's no research on that, but there can be a psychological importance with excessive excessive masturbation, though there is no any evidence on that. But the quality of the sperm is not affected. Yes, when you ejaculate very frequently, the volume of the semen can be low, but it can get recover within few days, the volume. The count can, again, it can be affected transiently, but it can get recover within few days. Because unlike women, the main, the testis will be producing a sperm every day, every minute, every hour. So, and it is quite good to ejaculate semen every second day to have a fresh population of sperm in the semen.
Yes, Daktari, thank you so much. Now, there's a question here that does sex position increase the chances of pregnancy?
Sex position, maybe the missionary position which can, after ejaculating the semen into the vagina, that can help the semen to remain in the vagina. That a specific position which can hold the semen for a longer time, for at least 1 hour, that is a better for pregnancy. Unlike in the standing position, when there is a chances that the semen can gravitationally can drop down.
Okay. Now, there's also a final question here about the myth and misconceptions about infertility. They're listed here among many. Because of time, I cannot mention all of them. That there's a myth that couples should try for a year before seeing an OBGYN. There's another one that infertility is a woman's fault. There's another one that women can't get pregnant after 35. And there's another one that using birth controls can cause infertility. Now, how do you react to this myth?
The first myth was?
Couples should try for a year before seeing an OBGYN.
Yeah, the young couple should try for 1 year at least before seeing OBGYN. But if the age of the couple is more than 35 years, then they should try six months. If they are above 40 years and trying for the baby, then they should wait for only three months. But also, if there are any risk factor, even if they are younger, if the couple is younger, but if they have a certain risk factor, then they should immediately see the OBGYN if they are looking for pregnancy. And those risk factors are, like if they have undergone any pelvic surgeries, which can increase the risk of blocked adhesion and the blocked fallopian tube, then they should go for early for the consultation. If they have undergone any chemotherapy for pelvic chemotherapy, then they should visit early.
Okay. Now, the second one is infertility is a woman's fault.
No, it's not only woman's fault, and it's no one's fault. I mean, there's no point on fixing anyone's fault. It's better to try the solution than fixing the problem. But medically, the fault can be either in male, 50% chance, or in women, 50% chance, or in both.
Okay. And the third one is women can't get pregnant after 35.
After 35, there is a decline in fertility, and there is some struggle in getting pregnancy. And this is mainly because of the number of egg going down after 35. But we have seen many cases who have many couple who after 35 they get pregnant naturally as well. But yes, the probability is a bit lower than a woman who is in early 30s or in 20s.
Okay. using birth control pills can cause infertility?
The birth control pill doesn't cause infertility, but while it is in use, yes, it causes protection from the pregnancy. But as soon as that birth control pill is stopped, the fertility returns back within few months, maybe after 2 months or 3 months. So that depends how long that that OC pill is used. Recently, we have encountered women who have been prescribed OC pill since she was 18 year, and she came to our facility when she was 30 years. So she has been using the OC pill for last 12 years, and then she came to our facility just for to check why she is not having a regular period. And then on ultrasound, what we observed was the ovarian function was still intact, but the uterus size was smaller, and that was because of the very chronic use of the oral contraceptive pill. So that should be avoided.
Okay. Thank you so much, Doc. Please hang on. I wish to take questions from Kariuki, then I go to Eunice, and then we will wind up.
Thanks, Leon, for the opportunity. I hope I'm audible. I think to the person who asked about the prospects of a woman getting a child after the age of 35 being a myth, I would like to let that person know that my wife is just barely 40. I think she's 39. And we have a 7-month-old healthy baby girl delivered naturally, so there's hope. But having said that, my name is Kariuki. I'm a natural treatment enthusiast. On this call, I think there was a counseling psychologist. There's been a sprinkling of some doctors. I'm just curious to know what members of the mainstream, medical industry who are on this call have to say about natural treatment. Not just necessarily for the male fertility, but female fertility. And the reason why I'm the reason why I'm asking this is because I'm a bit biased. I have to confess. I know of cases, people who are close to me, people who have struggled and spent, lots of money, including Rajesh in your clinic. I know your clinic on Hospital Road. The people who kind of despaired and they actually later gave birth using natural methods. Using natural medicine. So I just wanted to point out that I'm biased, but I'm curious nonetheless to hear what the medical practitioners on this call have to say about the efficacy or otherwise of natural treatment, what their take is. Thank you.
Thank you so much. Dr. Rajesh?
Yeah. So about the natural treatment after infertility treatment, there have been studies that have confirmed that there is a 10% chances of getting natural pregnancy after 1 or 2 cycles of failed IVF. So, and even we have encountered few cases where the IVF have been failed, and then next cycle, the couple getting the good news naturally. So that is not uncommon to get pregnant, but that also depends what indication the IVF is being done. Now, if the cause of infertility is say severe low sperm count or blocked tube, then the chances of getting natural pregnancy after failed IVF is very low. Virtually not possible. So, but those couple who have everything okay, like what do we say, unexplained infertility. So the chances are still there, because when a couple try naturally, that the chances of getting pregnancy naturally is around 5 to 10% every cycle. with natural try. With IUI, it is around like 15 to 20%. With IVF, it is like 50%. But the difference is like the IVF, there is only one cycle. You'll try only one cycle or 2 cycle or 3 cycle, and that 50% is only for that 1 cycle or 2 cycle or 3 cycle. But when you try naturally, that 5% or 10, even that 5 low, that is low percent though, 5 or 8%. But you try every other cycle, so that success rate gets compounded, and in one of the cycle, when you try, you get success. So that natural try should always be encouraged, even if you have gone through IVF. But what happens in couples, like they go through infertility treatment, so many years of waiting, they get depressed, even their sex life is affected. So they don't try naturally. The sexual intercourse is very infrequent. So they tend to miss out the natural opportunities. This has to be avoided. This has to be tackled.
Good point. Sorry, I forgot to mention that this was in one case. It was a case of a lady who had blocked fallopian, confirmed actually in your clinic. I think second IVF, and reconfirmed that second opinion by another clinic. Sorry, I didn't provide context, but good points. Thank you.
Thank you so much. Dr. Rajesh, there are a few more questions for you. There's someone who wishes to know: can a family sue you if they deliver, if the woman delivered a child with deformities via donor sperm? And what is the cost of donating a sperm? How much do you pay your sperm donors? And is there a national sperm bank?
These sperms, donor sperms, basically we borrow through agencies. So whenever a donor is required, so we ask the agency to provide that specific donor, and then they provide us. The charge that we ask for donor sperm in our clinic is around 50,000. And regarding if the deformity comes on the children, offspring, now that a bit difficult to answer, because we don't know whether that deformity has come through the male part or from the female part, or it is just that deformity. Sometimes the mutation can happen during the embryogenesis. So even if the sperm part is okay or egg part is okay, even then the deformity can come later in the womb life. So in the court of law, it will be quite difficult to prove that part.
Okay, thank you so much. As we wind up, just quick questions from...
Good evening, everyone. My name is Eunice Omolo. I'm a science and health journalist, formerly at Nation Media Group. Having covered sexual reproductive health stories, and I've learned a lot. I've met people who are battling infertility, and in Kenya, going through the Kenya Demographic Health Survey statistics, that we have 3 out of 10 women who face divorce or separation due to infertility issues in their marriage, and 1 out of 4 couples having the issues in the family. And basing it on what Leon and Helen Shikanda worked on, shooting blanks, and going back to what Zainab Wandati, the science editor at NTV, stated, that it is our job as journalists to highlight most of these stories. And I happened to speak to Millie Odhiambo, maybe Juma can react to that. Millie Odhiambo, who stated that when she proposed this bill, it's called the Assisted Reproductive Technology Bill of 2016, and it has gone to Parliament for 2 readings and nothing else for that. And I remember Dr. Manju has just spoken and said that the issues about deformities in terms of mutation after the sperm has been donated and implanted in a woman's uterus. I think as journalists, we need to tell more of these stories, trying to demystify. And part of demystification of the stories that we tell is if we take a good look at the story in United States, 1978, that's when the world had the first IVF baby. And this lady has given birth to a baby boy. That's around in the year 2000, and through natural method. So as I rejoin at what Zainab said, as our job as journalists is to try and educate the public, give solutions like we can have IVF, although it is still expensive, taking us back to why we need to tell, or rather make a lot of noise about that 2016 bill on having this bill tabled and having this bill to be able to regulate the cost of IVF in the country. Because I did a story on infertility as well, and the women who are most affected are women who are in the low-income area. So a woman being asked to pay 300,000 Kenya shillings for the IVF, the first cycle, and as Dr. said, she needs around 2 or 3 of them for the chances of fertility to happen. And we also need to tell stories of also, we've had cases, we tell stories of women who steal babies, and most of them when they're caught, it's I can't have a baby. And I think this was also the reason why Millie Odhiambo, the legislature, the MP who tabled the bill in the parliament, said there's a man who had infertility issues but killed the wife because the wife was impregnated by another man. So trying to bring the issue of infertility and putting the face on actual circumstances, or rather actual repercussions of what infertility is doing to our society, will at least, wake up the society and know that this is happening. So it is our job as journalists to also tell these stories. And as my editor, Mwinzi, always tells us that as journalists, we need to follow the numbers. We need to get these numbers, Why do we have 45% of infertility cases globally attributed to men, but we still have 3 out of 10 women divorced? So we need to talk to people. We need to put faces to the stories, as what Leon and Helen did, but also try and talk to people who've also gone through IVF and to successful. There's a speaker who said there's still some stigma around IVF babies. And I'm proud as a Kenyan that we have around almost 2,000 babies born through IVF. And although it is still expensive, we need to do that. And I have a question after doing the journalistic talking. My question goes to either of the doctors who can answer. This year, WHO released the tuberculosis data on the increase because of COVID-19 and how COVID-19 affected tuberculosis prevention and all that. And we also know one of the causes of infertility in men is genital tuberculosis. So one of the doctors can help us understand how prevalent is that, genital tuberculosis. Also, Dr. Catherine, if you can help us understand, can we work in fertility, like we have infertility cases, but then tracing it back to either genital tuberculosis or chlamydia or gonorrhea, and what advice would you give to, men in terms of seeking treatment before it gets to the point that it affects their genitalia? That's all, Leon. Thank you for the opportunity.
Okay, thank you. Dr. Catherine, real quick before we wind up, and with Kendi.
I didn't quite get the whole question, but I think I picked a bit about the role of STIs or sexually transmitted infections like gonorrhea in male infertility. Actually, even in female infertility, some infections which, if not treated, can lead to repeated infections, repeated inflammation that can lead to blocked tubes and all that. So sexually transmitted infections are a key factor in infertility generally because they alter the biology of the reproductive system. So it's not easy for sperms to pass through if your tubes are blocked, or if the woman's tubes are blocked, then the eggs also cannot pass through, or the fertilized embryo cannot pass through, and it can cause other problems. So it's important for people, men, women, to get early treatment. Of course, STIs can be prevented by using condoms. If having sex with, non-regular partners whose status is not known. So condoms are the first thing, but then if there's a suspicion of an STI, it's important to get it completely treated with the right treatment, complete the dose to avoid, future problems. Having said that, I think, as I've said, as I said earlier, the old, I would say maybe the old school treatment of infertility sort of used to revolve around women having their tubes opened and unblocked and washed, and there were all sorts of procedures which are happening. And I think from where technology is now, a lot of those are not necessary because they are quite ineffective, they are quite expensive, they can also be quite dangerous. So I think technology has moved away from dealing with blocked tubes and all that. So even in the unlikely event that this happens and somebody has a problem, there's still hope that they can still have a baby using the technologies that already exist. I think there was a question about tuberculosis, and I don't have the data for Kenya about what is going on there. But of course, anything that can alter the biology of the testes or the biology of the tubes, can have an impact and an effect on fertility, either through reducing the healthy tissue that produces sperm or, altering the pathway through which the sperm can reach, the penis during sex. So there are different ways, but in terms of the data, I don't have the statistics, so I wouldn't want to, go into statistics that I'm not quite familiar with. I wasn't sure that there was something about COVID. I'm not sure whether I had that, and if there is, maybe you can clarify. But even without clarifying, I think I can say that there are studies which show how COVID is affecting the reproductive system. So there are already it's still early days, but there are already studies which show that the virus itself affects the testes and other parts, and of course the stress and all this long COVID and all that. So there are other things which for now are not very clear, but some indications about COVID affecting fertility, and depending on the magnitude, that would be clearer once large-scale population studies are done to see how maybe fertility trends have shifted as a result of the pandemic or not. Over.
Thank you so much, Kendi. And then I will invite Mr. Mwinzi to wrap it up for us.
All right, thank you very much. I've really been enriched by this conversation. So I just really wanted to quickly give the correlation between chronic masturbation and infertility. Based on my work, I am a therapist. I am a psychologist practicing here in Nairobi. What I've seen in my line of work is whenever I work with couples and